I'm not going to wear the hat, but I thought with the title I had to do something to keep the theme going. I had all sorts of Harry Potter jokes, but I'll save you those. Thanks for coming. I will start off by applauding all of you, the work that you do, and this is the Healthcare Advocate Summit, so clearly you're all healthcare advocates in some way, shape, or form. We've all been patients, and we've had family members who have been patients, so I think we all know I certainly do the significant impact you can have on a patient's journey. It's hard work. Probably don't get as many thanks as you should. I know you're not paid enough, as much as you should be paid. So I will start off just by applauding you and thanking you on behalf of all the thanks you don't get to recognize the great work you do and the thought and care that you put into it. So clap, single person clap, but I thank you on behalf of many people who should. So let's see, what we're going to talk about is the often, not always, but often overlooked path to getting payers to pay for things known as exceptions. And I'm going to start off by giving you a little story, if I may. It's a true story. I'm going to hide the names and some specifics to protect the innocent, but this is something that happened to me, probably 14, give or take, years ago, right after I'd gotten into field reimbursement. And I worked for a large pharmaceutical company that had a big drug that just got approved, and it was literally like 2 weeks after approval where I got a phone call from one of our sales representatives letting me know that there was an oncologist in the state of Rhode Island. I think I can let that much slip. At least it was in Rhode Island. You can't figure out who it was based on that. And the doctor was trying to prescribe this new drug and just couldn't get coverage. The payer was the largest payer in the state. And so I called up the doctor. I'm like, let me see if I can help. I'd just been through all the training, the FRM training, so I was like newly minted and eager and like, I can fix this. And so I went through sort of the normal questions you'd ask, what's the scenario, what's going on, et cetera, and found out that the payer just said, well, the drug's newly approved, our pharmacy and therapeutics committee is meeting in 4 months, and at that time they'll put together a policy and they'll decide if they're going to cover a drug, if there's any step therapies or utilization management. Until then, we're not going to cover the drug. And I listened in training, so I knew to ask the question, well, what about their exceptions process? And the doctor said, well, what do you mean? I said, well, they should have an exceptions process to maybe work around this. Oh, well, let me check. So they checked, called me back, and I was told, no, they don't know what I'm talking about. They don't have an exception process. Their P&T committee is going to meet in 4 months, and at that time they'll formulate a policy, and they'll decide if the same stuff, right? So I was puzzled because this just contradicted everything I'd just been trained on. And so I made some phone calls. I called our person internally at the company who works with that payer in Rhode Island, and he told me the same exact thing. I mean, it was almost like everybody was reading off of a script. It was amazing. Drug just got approved. Their P&T committee meets in 4 months. I'm like, wow, wow. And this guy should know. Like, you're the director of national accounts covering this payer. Okay, but I couldn't let it go. So it was a drug, pharmacy benefit drug that was distributed through specialty pharmacies. So I called the specialty pharmacy, which, by the way, is a very large national specialty pharmacy. You would all know. I won't throw them under the bus and say it, but you would know them. And I got the same thing. It's like they had a meeting before I called to come up with the verbiage. P&T committee, 4 months, blah, blah. I'm like, wow, this is so weird. I guess I was lied to in training, but I still couldn't let it go. So I got on the internet, and 10 minutes later, I had a copy of the exception form for the payer. Got it to the doctor, and I think it was a day, maybe 2 at the most later, they called me back to say the drug got approved and the patient's going to start therapy. I will never, ever forget that because it gave me the confidence that the training I got maybe wasn't so bad after all, but also that this is just something that's a lot more hidden than it should be. And I've worked with a lot of organizations, healthcare organizations from the small mom and pop. I live in New Hampshire, so you can imagine some of the folks I work with, but I also cover Boston and all of New England. So from the smaller ones to the very larger ones, and to this day, it's not uncommon for this to just be something that just people are unaware of. And even when I come to the Healthcare Advocate Summit over the last day, you hear appeals and you hear prior authorizations, and that typically is what you hear. I almost never hear the word exception used. Now, maybe I'm just not in the right crowd. That's possible. You may have been hearing it more than me. But it's a thing, and it's out there. And so that's what I'm going to talk about today. And it can sometimes be the make or break. When I talk about open sesame, at the first slide, it can open the door that would otherwise remain closed forever. So I'm going to talk just a little bit about background of what this is. I'm going to tell you some things that you know, but just to sort of set the stage, make sure we're on the, speaking the same language. And then talk a little bit about how an exception is different. It is separate and distinct from a prior authorization or an appeal. They are not the same thing. What makes it unique? What are some examples when an exception would be necessary or appropriate? And talk about some different payer policies. Part of the thing that makes this interesting, I'll say interesting because it's a more positive word than other ones I might choose to use, is that different types of payers are legislated and regulated differently. Right, so you have small group, you have individual, small group, large group, self-insured, association plans, exchange, you have all these different types of plans, and the laws that govern them are not the same. That would be great if it was, but this is the United States healthcare system, and that's just not the way we do things. So I'm going to talk a little bit about that dynamic too, because it's an underlying element of all this stuff. So, all right, so I got ahead of myself. I already gave the first line away. But what we know is that Medicare and Medicaid are generally required to cover drugs according to their FDA-approved label. They have to. Whether they want to or not, they have to do it. When the use is consistent with that FDA-approved label, and in the case of Medicare, there's 6 compendia that if it's used according to these 6 compendia, even if it's off-label, they got to cover it. It's their own policy. Interestingly, Tennessee is the one state that does not have to cover, Tennessee Medicaid does not have to cover all drugs according to their FDA-approved label. They got a waiver. And there's a number of states that have gone and pursued a waiver to let them exclude drugs. Tennessee's the only one that actually got it. But they still have to cover the 6 drugs in the Part D, the same 6 drugs in Medicare Part D, they're protected classes. And anticonvulsants, antineoplastics, you could look them up. I don't have them memorized, but there's 6 classes. They have to basically cover all those drugs. So that still applies. But other types of drug classes, they can pick and choose. It's the only state that you can do that, though. And that's day 1 of approval, by the way. So don't let them tell you that that's not the case, because it is. Medicare Advantage plans, as part of Medicare, fall under that same requirement. They have to cover drugs when used according to their FDA-approved label. But Medicare Advantage can do utilization management. So quantity limits, step therapies, all sorts of things to sort of direct to the drugs they'd rather have you use, but they have to cover them. Fee-for-service Medicare Part B does not deploy a formulary, so if it's original, as they say, Medicare Part B, it's going to be covered without any steps. And Medicaid can also use utilization management, so covered but potentially with some caveats or requirements on that. And I think I already talked about the other protected class piece. So those are universals. Anybody, if there's any doubters on that, believe me, it's true. Look it up. I know even like internally, I've gotten questions on the whole Medicaid thing, and they do have to cover it. They may not like to do it. And if you ever have a provider who prescribes a drug for a Medicaid patient according to the FDA-approved label, et cetera, and you get pushback, I'd call your state Medicaid and argue that, because that's not right. It's against the nationally published policy. However, commercial plans are governed by different regulations based on the type of plan I talked about a minute ago. It's not quite as cut and dry. Like the governmental stuff, it's all public knowledge, so it's easy to look it up. Or not easy, but you can do it. Commercial plans, they very often don't publish their policies, and if they do, they make it kind of hard to find. So I can't make quite as many blanket statements on the commercial as I can on government, but I can make some, as I will in a few minutes. Based on the prior slide, covered means they have to cover it, but it doesn't mean necessarily there's no restrictions. So it's easy, for me in the old days when I was a sales rep to walk in and, hey, yeah, my drug's covered. You have to do 20 things first, but it's covered. It's not always quite so cut and dry, especially with certain programs that have utilization management. But it will be covered if you can meet the criteria. And so these are different types of utilization management that you're all probably painfully familiar with at the bottom. Won't go into that. And so you're all very familiar, I imagine, with prior authorization. It's a published policy like that Blue Cross and, oops, I almost gave the payer name, the Rhode Island plan, whoops. The whole 4-month story, well, that was when they were going to sit down and come up with their policy. And it's a published policy. You can find it. They've assessed the data. They've looked at the clinical value, and they've said, we're going to cover it, or no, we're not going to cover it, or we're going to cover it, but only if you check these boxes. So it's a formal document, right? And the prior authorization could include a lot of things. It could include you have to try and fail on another drug, or show no response to another drug, or lab tests. Also, patient, and these are good things in many cases. Like if it's if the prior authorization requires to show, a certain clinical condition as evidence from a lab test before the drug will get approved, well, that maybe is a really good thing because that means that the drug's going to work for that patient, right? If their condition is consistent. So that's not all prior authorization requirements are a good thing, but they're not all evil either. And so it's a clear document. So that's what a prior auth is. We don't like them, generally speaking, but they're not all bad. There's good reasons for them. An appeal is a request for a health insurance plan to reconsider its decision to deny coverage. And so I'm going to mention one drug. This is a completely non-promotional thing, but it's just I'm familiar with this because it's my company's drug, so I'll say it. So we have an IV iron drug, and there's a bunch of different IV iron drugs that are out there. And several different large national insurance plans have our drug as a step therapy. You have to try 2, sometimes 3 of the preferred ones before you can use ours. So if you have not tried, let's just say 2 of the preferred ones, and you submit a prior auth, they're going to deny it because you haven't met the criteria of the prior auth, right? If you then appeal that, they're still going to deny it because nothing's changed. You still haven't met the criteria, so there's nothing really to appeal, right? They're going to say, well, this is our policy, and you need to tell us, what did we do wrong? We didn't do anything wrong. We told you had to try and fail 2. You didn't, so we're not going to give you a yes, so the appeal will fail. That's where the exception comes into play. And the exception is the hidden door. It's there, if you look closely, that is often overlooked or missed, and understandably so, because they don't talk to you about this. They're not forthcoming. Even in the case with the instance I was describing at the beginning, the doctor's office, I think I left this part out, called the plan, maybe I said it, and the plan told them, no. And so they're not, I don't know, the cynic in me says they don't want you to really know about this. I'm sure they do, but they're just not good at telling you, which is why it's a hidden door. And so the exception basically is if you think of the prior auth as a published policy, it's where they stand, it's what you need to do to get them to say yes, hi Amy, then the exception is different where you're going to, and I'm sort of paraphrasing this or using my own language, but the exception is where you go to the plan and you say, hey look, I know what your policy is. I read it, love it, great policy, but for this patient, the policy is not the best medical choice. And so I'm asking you to make an exception to your normal published policy. And the tough part is, well, now here's why. You have to explain it to them in a way that makes sense, right? And so, but that's like a key. If you can remember anything about what I'm saying right now, and we'll continue to say, remember that, because I think that'll be like the guiding light, is the exception is you're going to them and you're saying, I know what your policy is. I'm asking you to go outside policy for medical necessity because it's in the best interest of the patient. I know I haven't satisfied your policy. I'm not going to satisfy your policy. I have no intention of doing it. But you and I both want the best thing for Mr. Jones or Mrs. Jones, and so let me explain to you why what I want to do outside policy is the best thing for Mr. Jones or Mrs. Jones. And so that's when an exception. Does that make sense? It's kind of simple, right? But they'll never tell you, or I shouldn't say never. It's very uncommon for them to tell you if you call them up. And it can even apply to things like exclusions. So if it's the drug's on in formulary exclusion, like we're just not going to cover it, if you can prove to them that it's necessary for the patient, they'll cover it. All right, little flow chart I put together. So is the drug on the plan's formulary? If it's a yes, that's cool because things get easy. Does it require a PA? No. It's green because that means you can get it approved, right? It's easy. It's on the formulary, no prior auth, good. It's good to go. Well, let's say it does require prior auth. Are the requirements for the prior auth met? If it's a yes, well, you submit the prior auth, and they're going to say yes, as long as you satisfy the document and the policy, right? If they're not, however, and the reason that they're not is patient-oriented, the patient can't use the preferred drugs because they'll have an adverse reaction, or they've tried them and they failed, or the preferred drugs, they require, 5 infusions in a week, and the one that you want to use is only 1 infusion a week, and the patient just can't get there 5 times a week. That's a time toxicity issue, right? But the requirements are not met. Is it medically necessary? That's the linchpin of all this. They'll never approve an exception because you like the sales rep or the doctor likes the drug just because, right? Well, I wish they would. Maybe they would, but they're probably not going to do that. You need to prove your case of medical necessity, and if you can do that, that's where you get an approval. Is it medically necessary, and can you prove it? If it's yes, you request the exception, and you should get it. If it's not, if it's, the doctor owns stock in the company, or we like the rep or whatever, they're not going to say yes, and they shouldn't. Really, be objective. Even if it's, my company makes it, probably shouldn't. That's okay. But that's sort of the flow of how to maybe think about this. And some situations that could apply. The story I told at the beginning, a newly FDA-approved drug. The payers haven't had a chance to sit down and think about it yet. They probably don't have it loaded into their electronic systems. Like, it doesn't exist in their eyes. If it's medically necessary, then that's where you could pursue the exception. If the other ones are pretty obvious. I kind of talked about that. The patient just can't use the preferred drug for various medical reasons. Maybe there's an access to care issue. Time toxicity, dosing schedule, who knows? And it could be a lot of other things, too. This is patient-specific, right? So there's no one thing that's going to work for every patient. And that's sort of the point. It's got to be medically necessary for that one patient. But if that medical necessity exists, you've got a good chance for this. And so these are just some of maybe 1,000 reasons to give you a sense as to what this is all about. The elements of success are be objective. And would a third party who has no knowledge of the patient, you, the practice, would they look at the case you're making and think it's a strong, reasonable case that a logical person would approve? Think about it, from somebody else's point of view. And then, hugely important, what is the payer's specific process? They're all going to be slightly different, although the commonalities are pretty central, to be quite honest with you. A lot of times, an exception is almost the same thing as a prior auth. It could be the same form, believe it or not. Often it could include a peer-to-peer review, letter of medical necessity. You know these things. So if you hear like peer-to-peer, that's not happening as part of a prior auth. That's happening as part of an exception. They may not be calling it that. They probably are internally, but that's an important thing to be aware. I have a note there about provider, a similar specialty. I'll talk more about that in a second. But the idea behind that is and I come from the world of oncology, so if I reference oncology all the time, forgive me for that. But if someone is pursuing an exception for somebody who has cancer and it's a chemotherapy drug, and the peer-to-peer review is with a pediatrician, the pediatrician probably doesn't have the background and education to make an informed judgment on whether that exception request is righteous or not. Right? So you can request review by a like or similar provider, meaning if it's an oncologist, or dermatology, a dermatologist. Somebody who's in a better position to make an informed judgment. They still may say no, but they'll have a better background and capability of making the right call. Some things just as silly as like timelines, I shouldn't say silly because I get it, but if you submit that prior auth, exception if you have 48 hours after the initial contact to submit all the paperwork and you take 49, they're just looking for an excuse to tell you no. So make sure it's 47 hours and 59 minutes, not over 48. But know that payers exactly what they want you to do, when they want you to do it, what forms, whatever the process is, know that. And it could be different, it probably will. 90% of the time it'll be very, very similar to everybody else, but if you make one mistake, it could be the one thing that gets them to say no. Just give them an excuse, right? And then supporting documentation, patient medical history, the drug package inserts, any objective third-party papers, Journal of American Medical Association, you name it, you know the publications. Because again, that supports the idea that it's not just you who agrees with this, it's some other informed third-party, well-educated group of people who agree with what you're saying. So it's just making your case. Think about it like a lawyer. You're not going to court, but if you think about it like that, it'll help. Some fallouts or lookouts are different terminology. They don't always call it an exception. They may call it, in the case of Part D, they call it a coverage determination. They may call it who knows what. But and you may need to wordsmith it. At the end of the day, if you're chasing them around the tree and they're like, no, we don't have a coverage determination, we don't have an exception, we don't have this, then you may just have to fall back and say, hey, look, I want to know what process you have whereby I can request something for this patient outside of normal policy. And if you spell it out for them like that, hopefully the light bulb will go off, because they almost surely have it. All Medicare Part D plans have to, by law, they have to do it. Medicaid and original Medicare, they have to cover things according to their FDA-approved label. So, in the case of Medicaid, they could have utilization management. But again, medical necessity, if there's a case there that you can make a request for an exception that's legit, go for it. Some states have passed laws requiring state legislated payers to have an exceptions process, even in the commercial space. Plans that provide essential health benefits must offer an exceptions process. Those are really individual and small group plans. Most patients who aren't in Medicare have insurance through a self-insured employer. So in self-insured in markets, about 50% of the population, and about 60% of those people are in self-insured employer plans. They don't have to do this. The good news is they almost always will. 2 reasons. One, because it's the right thing to do for their employees. And the second is NCQA certification. So the National Committee on Quality Assurance is a body that will look at a health plan's policies, procedures, their timelines, how they conduct business, and if all the requirements are satisfied, they'll get this NCQA stamp of approval, which all the plans want. Because if a plan is NCQA certified, then the beneficiaries of that plan, enrollees, can have confidence that it's a good plan. So self-insured employers, they'll do it because it's the right thing for their employees, and they want to be NCQA certified. So that's a biggie. And pharmaceuticals, whether they're pharmacy benefit or medical benefit, fall under this umbrella. I'll also tell you this, that exceptions can be requested for all sorts of things: lab tests, procedures, office visits, you name it. You can request an exception for cost shares, for out-of-network coverage, all sorts of things. If it's the best thing for the patient, you can do it. And I'm almost out of time, so what I would say is, when you pursue this, you are going to be told, if you do it enough, actually if you do it more than once, you're going to be told, no, we don't have that, I don't know what you're talking about. Almost certainly, that's not true. There are some types that won't do it, but most plans will have it. So I would encourage you to not take no until you've really pushed. It may be just the person you have on the other end of the phone doesn't understand what you're talking about because nobody's ever asked it before, because people don't know to ask for this. But it can make all the difference. And another little tidbit that I don't have on the slide is plan idiosyncrasies are such that there was one plan that last time I looked, probably 2 years ago, this may still be the case, was a national plan that if you requested an appeal before an exception, you waived your right to ask for an exception. So you have to know their policies. Because the example before, like if they have a prior auth and you haven't satisfied the prior auth and you go to an appeal, you've basically just lost. It's crazy, but it's true. Yes?
Hold on, let me bring you the mic.
Oh.
So I heard you say that you could use the exceptions for different things. Would it also be applicable if a plan has an exclusion of coverage? I had a consumer recently where newly 18-year-old had I think it was something with his jaw, and there was an exemption or exclusion, something, how it was worded, where the plan would not cover anything related to that diagnosis. Even though it was severely affecting his day-to-day, they would not cover this procedure that would change the way he lives his day-to-day. Would this be something I could potentially use for that? Potentially,
yeah. I would fight that fight. I think there's a chance to get that. Things that probably are not worth fighting for. I mean, cosmetic, things that are not necessarily directly related to and I hate to say like not related to health because it could be a mental health thing, right? But some things that plans will exclude and you're just not going to get them covered. Like if I wanted, cheek implants or I don't know, whatever. I could use a lot of work, but they're probably not going to cover that. It's a hard thing to make a case for medical necessity for that. But what you're describing to me is in the realm of what could be possible. Yes.
Hi, thank you. Quick question on the self-funded plans. A group of patient organizations have recently had a lot of meetings with the Department of Labor, CMS, and Treasury on the exceptions specifically. So while a self-funded plan does not have to cover any of the essential health benefits, it's generally understood and agreed that if they do cover, let's say, prescription drugs, then they have to use an HHS-approved benchmark plan. I know that's a lot of background.
I know exactly what you're talking about. Yep.
So we have reached out this past year, just a few months ago. There was a copay maximizer issue where they said a lot of plans were covering drugs, but said there were not essential health benefits. DOL and others clarified, and CMS said, okay, no, you can't play those games anymore. If a drug is covered, it's an essential health benefit, and therefore all the cost sharing applies. We've reached out, about 25 groups, we've reached out to DOL asking for clarification. In the same provision of the ACA that addresses what I just spoke of, it says if a drug is not covered, there must be a process for medical necessity, an exceptions process for medical necessity. We've asked DOL, and it's still pending with them, and as well as Treasury and HHS, to please also clarify and confirm that exceptions process for a self-funded plan that does provide drug coverage, so they are willingly providing drug coverage, that they too must provide an exceptions process. We've not heard back yet, but we're trying to say, much like they were saying if a drug was covered, you can't play the game and say it's not an EHB. Yep. We're saying that same provision has a requirement of an exception. So we're hoping that they come back, because that would be a huge gain for all people covered in a self-funded plan.
Thank you for doing that. Can I sign the petition? Because I would totally do it. That's a great. Where do you work?
I'm at Cancer Care.
What state?
I'm in the DC area.
Okay. Yeah, it's funny. So the thing she was talking about, it's a sneaky little trick. Sorry, I shouldn't say that. It's an interesting business strategy that some plans have taken, that if you're a large group or a self-insured employer, you don't have to provide essential health benefits. There's 10 categories of essential health benefits, one of which is drugs. But the way I've always interpreted it, and I'm not a lawyer, so I've interpreted it incorrectly, sort of, but if they do cover essential health benefits, they have to count towards cost sharing and a lot of the Affordable Care Act provisions. So what they've been doing is they would pull out certain drugs and say, well, we'll cover it, but we're going to deem it a non-essential health benefit. So it doesn't have to count towards your out-of-pocket max or any of these things, which is just crazy to me. And what she was saying, what's your name? Kim. What Kim was just saying was a very recent, clarification, shall we say, of the law that they can't do that anymore. So thank goodness for that. Although last I read, that applied to the small group and individual markets, but they're looking to get clarification on large. Did they provide that clarification? That it sounded like large group and self-insured. They were in the future going to clarify for them.
Yeah,
is the last I knew.
Yeah, they said there's an FAQ they put out, and they said that they do plan on aligning that for self-funded plans. It will be through a rulemaking process. It hasn't happened yet.
Yeah, checks in the mail.
Yeah, right. Exactly.
But it's a really good thing, at least for those two types of plans, and you've got to, at least I'm going to be hopeful and say that for the large group and self-insured, they're going to do it too, because how can you not, right? And as a result of that, I'm going back on my presentation from 2 years ago, I think, that will basically render maximizers a moot point, because you can't do a maximizer because they're based on pulling these drugs and calling them non-essential health benefits. So it's a really, really good thing. And the reason I asked where you worked is that I have heard that in Nevada, that there's been a ton of pushback, and I don't know if it's organized. I don't know enough of the detail, but it sounds like that there is the potential at sort of the local level to take that ruling that came down and take it at the state level and say, look, this is a federal ruling, and so we're not going to wait for them to clarify. We're going to push you to clarify right now and cover these things. Anyway, I'm getting a little bit off track, but that's a really big deal. So thank you for bringing that up.
Unfortunately, we are at time, but if you have any additional questions for Ned, if you go on the Swap Card app, click on this session, you can type your question in there, and we will get it back to you as soon as possible. Thank you so much, Ned, for the insights. We definitely appreciate it.
Thanks, everybody.